Mankind Pharma welcomes you to this live webinar on demystifying telemedicine guidelines and role of telehealth in management of COVID-19. As healthcare providers, we are in unprecedented times. Across the country and around the world, the COVID-19 pandemic has led to scarcity of resources on the healthcare front. At a time when social distancing is amongst the most effective measures used in the fight against this deadly disease, telemedicine and telehealth is stepping up as a key technology for safe and effective communication. The World Health Organization has mentioned telemedicine amongst the essential services in strengthening healthcare system in response to COVID-19. In India, now that regulations have been passed regarding telemedicine, doctors should have no concern in providing remote healthcare. From a doctor's perspective, it will be easier, more convenient, and equally, if not more remunerative. To enlighten us on this very important subject, we are fortunate to have with us Professor K. Ganapathy here today. Professor Ganapathy was the first neurosurgeon in South Asia to be formally trained in stereotactic radiosurgery in 1995 and later in robotic surgery in 2008. He is also credited to be the first in South Asia to get a PhD in neuroimaging. Professor Ganapathy has been working relentlessly from 1999 for the growth and development of telemedicine in India. He is the director of the Apollo Telemedicine Networking Foundation and Apollo Telehealth Services, the oldest multi-speciality telemedicine network in South Asia. Professor Ganapathy is the past president of Telemedicine Society of India and also Neurological Society of India. He is a professor emeritus at Dr. MGR, Tamil Nadu Medical University, Chennai. He is on the editorial board of 4 international journals in telemedicine, 5 international and 3 national journals in neurosciences. During the last 45 years, Professor Ganapathy has presented 511 papers in national and 177 papers in international meetings. He has published 243 scientific papers and 16 chapters in books. With this, I would like to invite Professor Ganapathy to deliver his talk. And I would also request all the participating doctors to post their queries, which we would take after the session is over. Over to you, Professor Ganapathy.
Good evening, everybody. At the outset, I'm thankful to the organizers for giving me this opportunity to share with you what I have been actively involved in for the last 22 years. I'm going to divide my talk into 3 parts actually. I'll very quickly take you through what exactly is telemedicine. And after that, I'm going to talk about the new guidelines which has brought to the forefront. Everybody now is interested in telemedicine thanks to the new guidelines. And after that, I'm going to talk about why telehealth is absolutely essential today in light of the pandemic. Now, let's start from the very beginning. Telemedicine is a broad term which encompasses all that goes to provide healthcare remotely. I always say that today distance has become meaningless. In fact, geography has become history. Today, not today really, 22 years ago, we started this. You can examine a patient, you can listen to a patient, take the history, examine him virtually, investigate, and also make a provisional diagnosis, sometimes even a final diagnosis, and send him a prescription or tell him what is to be done, all with the patient and the beneficiary located elsewhere. This presupposes that you have adequate hardware, software, and of course, the most important thing, connectivity. Today, connectivity in India is at its best. I am right now talking to thousands of doctors located all over the country, thanks to the excellent internet work facility which we have. Now, today again, one needs to investigate a patient. So any telemedicine system should have the facility to acquire images, store images, retrieve these images, display these images, enable you to digitally manipulate these images wherever you are. Now, this again implies orientation, training, customization. I strongly believe that a solution is not a solution unless it is universally available 24 by 7 to anyone, anytime, anywhere, with the sole purpose of providing quality, affordable healthcare to every one of us. Of course, one necessarily has to be compliant with regulations. It has to be self-sustaining and future ready. Revenue generation is not, to me, a dirty word. Unless you have revenue generation, it cannot be self-sustaining. Now let's divide telemedicine consultation essentially into two formats: synchronous and asynchronous. Synchronous means real-time consultation where the patient is in front of me. It may be on a smartphone, a laptop, a desktop, and what have you. Now, history can be sent by a text, history examination can be done virtually, and all investigations, whether it be laboratory reports, an X-ray, an ultrasound, a CT, an MR, whatever it is, can be sent. Today, we have the technology. If you happen to be a super specialist and you actually want to look at a slide, you can even send histopathology and cytopathology specimens over the internet. Today, it is possible for you to see in real time a live procedure, an invasive procedure. Many of you are cardiologists, and a fellow cardiologist is in the cath lab doing a stenting. You can actually see it from wherever you are. This, of course, requires a very high bandwidth. Now, let's look at the real world. I have divided the world into BC and AC. I used to preface my earlier talks by saying BC, that I was the last neurosurgeon in India, the group of neurosurgeons who was trained in the BC era, before computers and before Christ are one and the same. When I got trained as a qualified as a neurosurgeon, there was no CT scan in India. Today, ladies and gentlemen, I use the same terminology, but in a different setting. BC is before Corona and AC is after Corona. How is the world going to be after Corona? Just see this. This came in the media yesterday. TCS is one of the world's largest companies, one of the most respected companies in India. And they have publicly declared that within the next 60 months, 75% of their 4.5 lakh employees will permanently work from home. I repeat, you can see that in large size font. In other words, WFH, or work from home, is not, I repeat, not a COVID-19 situation. This is going to be a part of our life. The world has been turned upside down. Whether you like it or not, the world is never, ever going to be the same. Now, there are so many advantages in this. TCS says it will require less office space. It will require less vehicles to transport its thousands and tens of thousands of employees to their office. Imagine what is going to happen. Less vehicles on the road, less pollution, less petrol, less etc., etc. You know what it is. When this is so, why can't you and I, why can't we sit at home and do what we are trained for, instead of spending half an hour, 1.5 hours just in trying to reach the hospital? Why do you need to invest a large sum of money in having air-conditioned offices with a secretary outside, appointments to be fixed, etc.? All this, ladies and gentlemen, is going to turn purely from an ROI perspective, a return on investment. And those of you who do have an ROI perspective, please remember that you can do 97% of whatever you're doing today from the comfort of your own house. So this is the future. Today, for this talk, I have borrowed these slides from the internet, but I'm sure the way things are going, in another 6 months or 9 months, I will see similar in India itself. Look at the guy on the right. He is not in Houston NASA Mission Control Center. He is an MD General Medicine. He is an internist, and this is how his room is already there. And again, on the lower right left-hand side, you can see a person with a TIA, RIND. She takes her own BP. Today, we have POCD. Sorry. Point of care diagnostics. With a drop of blood, you can do liver function tests, renal function tests, cardiac enzymes, troponin 1, troponin 2, etc., etc. I have been using all this in the Himalayas for the last 2.5 years. POCD is going to be the name of the game, and whatever investigations you want, you can do it at home. All of you are familiar with FDA-approved ECG machines, which can fit into your pocket. Several years ago, I broached this topic. Are we ready for a hospital which has no patients? I never thought that in my lifetime I will really see this happen. But ladies and gentlemen, this is going to happen. The hospital of the future will only have trauma cases, will only have patients posted for surgical procedures, a liver transplant, a heart transplant, and what have you. You will find that medical wards, inpatients to medical wards will become less and less, and this is what is going to happen in the real world. About 10 years ago, I used to write in the Hindu quite often, and I remember this particular article, The Doctor in Your Pocket. Today, I would write an article saying a hospital in your pocket, a laboratory in your pocket, because every one of them is doable. We have ultrasound machines today, multi-frequency transducers, FDA approved, which can fit into your pocket, and you can do this. Echocardiograms, gone are the days where huge echo machines, which needed a lift for you to transport. All that has become truly mobile. It can fit into your briefcase. Now, I again understand that most of you are physicians. Now, thanks to this talk, I educated myself considerably in the last couple of days. I was amazed that there were hundreds of publications on scientific evidence and data, statistically significant, showing that remote healthcare in the management of diabetes is far better than a face-to-face encounter. Now, you can go through all these papers yourself. Just look at this. Whether it is gestational diabetes, whether it is pre-existing diabetes, what have you. Diabetes telehealth in the 21st century, log into the future of medicine. I don't know whether you're able to see this slide properly, but in front of me, I can see that there was a 29% increase in compliance and adherence to HbA1c testing. The control group showed improvement, but much less than in the telehealth group, etc., etc. Blood pressure came down, serum cholesterol, lipid profile, every one of them. Compliance and adherence is the name of the game. All chronic diseases, whether it be diabetes, hypertension, convulsions, seizure disorder, and what have you, compliance and adherence. And there are enough studies which show that telemedicine or distance care or remote healthcare is equally good. Now, look at this. Web-based intervention for diet and physical activity, lifestyle modification. It's much more effective when you actually show photographs of the diet. What is the amount of calories, proteins, carbohydrates, fat, etc. Exercises to be done. Nothing like discussing it with animations and videos instead of just unemotionally telling a person that you must do a lifestyle modification. I'm just going to give you a few examples from the real world. Ladies and gentlemen, we have been running telemedicine for the last 21 years, and I'm just going to show you a few examples. This was from the Himalayas at a height of 14,500 feet. The temperature was minus 25 degrees. 5 months in a year, the roads are totally blocked. Lahul and Spiti, Kaza and Keelong. Till Apollo Telehealth Services went in and set up, people had to be taken by helicopter. And you know how difficult it is to get sanctioned permission to get a helicopter. Here is a person whom we diagnosed a myocardial infarction as it was evolving. The first ECG was normal, but I have a wonderful set of doctors, and my doctor said, I don't like the look of your face. His BP is not really what it should be. Told the nurse who was trained in the Himalayas, don't send him back. Repeat the ECG after 45 minutes, and you can see what the ECG shows. Thrombolysis were done with streptokinase. Today, 14 patients we have picked up myocardial infarction as they were evolving from a distance of 3,000 kilometers. We again run the world's largest tele-emergency services. Papers have been published, papers have been presented at international conferences. As of a few days ago, it was 1,515 emergency cases which we have treated. Since you are primarily physicians, I'm not going into the surgical problems which we treated. Here is a patient with ventricular fibrillation, supraventricular tachycardia, 240 pulse rate. It happened on a Saturday evening. The particular nurse whom we had trained was on leave that day, and we had the equivalent of an ASHA or an attender, a lady attender. She couldn't spell the word fibrillator, had never seen a fibrillator in her life. But then our main hospital emergency ward is one of the best equipped wards in the country. And young doctor, he said, don't you worry, I will handhold you. I have internet, I have a webcam, that's all that I want. He got a mannequin and he showed to this little girl in far, far away how to apply the pads, how much amperage, milliampere, joules, that, this, etc. Demonstrated it on a mannequin, and this girl did it. And the pulse rate came down, and you can see a few hours later, the patient's post stabilized. Today, we have done this for more than 9 patients so far. At that time, we did not have medication. Now, of course, we use medication instead of doing it. Just a few clinical examples. I personally think it's a crime today to make this little child travel 2,000 miles so that the pediatric cardiac surgeon can just inspect the wound. Today, we have digital stethoscope, which can transmit sound. It's so silly, according to me, for a doctor to put a chest piece over the chest of a patient. Those days are gone. There was an article in the Lancet called The Obituary of the Stethoscope, which was written 2 years ago. In the future, ladies and gentlemen, I remember as a medical student, third heart sound, fourth heart sound, ejection click, pansystolic, mid-diastolic. I mean, it really looks ridiculous in 2020 when you have a pocket-shaped echocardiogram, which will tell you the physiology. Unfortunately, we were all so overwhelmed by work that we were unable to publish the way people in Western countries do. I hope you are able to listen to this echocardiogram. The slide on the bottom, I had a wonderful pediatric cardiologist with me, Prem Shekhar. Unfortunately, he left us after some time. 138 pediatric echocardiograms. He supervised from Madras with a technician doing it in the village of Aruganda, transmitted these 138 echocardiograms, made a diagnosis, and decided what was done. Nothing great about it, you may say, but see the date. This was done in 2001, 19 years ago, when the rest of the world had no idea of tele-echocardiography. We were doing this. Unfortunately, we were just too far ahead of the time. And in spite of all our efforts, it is impossible for us to persuade either physicians or cardiologists that echocardiograms can be done remotely. I hope the presence of the COVID-19 infection will change everybody's response, and I'm sure that all this will be accepted. Teledermatology, the simplest with telemedicine. We have done more than 7,000 cases. I have 4 dermatologists who are involved in major public-private partnership. This is, of course, excluding their private practice. And today, more than 99% of skin conditions have been diagnosed correctly. And there's no, obviously, there were 1 or 2 instances where the condition could have become serious. Stevens-Johnson syndrome, the dermatologist immediately said the patient has to be admitted. Teledermatology is the simplest. I'm sure at first glance, you may think I made a mistake in making this slide. Ladies and gentlemen, this is not a mistake. This is the real world. As on 24th April, lockdown or no lockdown, we in the healthcare profession provide services, and you can see this is a real-time live dashboard provided by the government of Andhra Pradesh. Mukhyamantri EI Kendram, you can see 1.4 million visits have been made to 115 ophthalmology vision centers. We have done more than 350,000 fundus images. I'm just writing up a paper on retinal scanning from remotely. 30 ophthalmic doctors from Chennai handle this in 115 centers in Andhra Pradesh. We have been doing this for the last 2 years. And to us, it's extremely simple. We have a community health center, and we don't even have optometrists. Don't think these are qualified optometrists. Some of them are, but some of them are not. They are trained. They are made to sit in front of a fundus camera, and ophthalmologists in Chennai are able to look at it, report it, semi-automated, automated diagnosis. And look at the quality of the pictures. They are way better than what you would see through an ophthalmoscope. And again, we have been able to pick up not just diabetic retinopathy, hypertensive retinopathy, but macular degeneration, glaucoma, and so on. February 2020, just look at the statistics. Now, I want to spend 2-3 minutes here because I want to convince every one of you who generally are physicians that this is a routine so far as we are concerned. 1 million consultations have been provided, out of which specialist teleconsultations are a staggering figure of 9.87 lakh. This again is about 6 weeks old. Because of the lockdown, I was not able to get the latest statistics. Normally, I would have got the statistics till this morning. And out of this, at least 70% are general medicine, MD general medicine. We also have rheumatology, endocrinology, and a few other specialists. But most of them, these consultations are given by MD general medicine people, A, from the comfort of their home, B, from a very large call center, which Apollo Hospitals has in Hyderabad. Repeat consultations, lab referrals, 1.7 million laboratory tests have been done, and all this have quality control, absolute NABH accredited, every sort of quality control, and telementoring is done from Hyderabad remotely. These laboratories, the lab technicians are trained, handheld, all this is done remotely. Immunization visits, everything. Why do you think that you need to be in front of a doctor, that you have to go to your hospital, have to go to your outpatient department? This is not necessary at all. And believe me, it will be a great experience for both. We also run a telemedicine center in NTPC. Oh, sorry, I think I got the wrong slide. Sorry about that. Okay, the next slide, this is in the Himachal Pradesh. Again, 17,900 consultations given at 14,500 feet in the Himalayas. A good part of them includes consultations given by MD general medicine people. This is in the Assam-China border in rural Assam. National Thermal Power Corporation, one of India's largest Ratna companies, contributing to almost 15% of power in India. This was considered a punishment posting because this was a notified area, a Naxalite infested area. People were just reluctant to go and work there. No doctor was willing to live there, even though he was offered 3 times the salary normally paid. So what did we do? We took up the challenge. One of our own doctors is there. We have a nurse, a physiotherapist, and so on, and specialty teleconsultations. An MD from Madras has given 1,538 teleconsultations so far in a small factory with a population of less than 2,500. Obstetrics and gynecology, we have 3 obstetricians, gynecologists, 1,200 consultations. They have picked up anemia in pregnancy, pre-existing diabetes, gestational diabetes, teleconsultation, counseling for HIV patients, and so on. All this has been done. I think in the time available, I've given you a quick overview of the power of telemedicine. I'll illustrate with more clinical examples when I illustrate on what the repercussions are with the new guidelines. Now, let me spend the next few minutes trying to tell you why everybody has woken up. It's not just in India, the whole world has woken up and realized that remote healthcare is the new normal, as you would like to call it. Unfortunately, social distancing is going to be a part of our life for a long, long time. It is not the absolute lockout for the next 96 hours. Pandemics, again, are not absolutely unknown, though they are very rare. The very word quarantine came in 1348 for 40 days when the first concept of isolation came. Again, in 1918, 102 years earlier, the Spanish influenza led to the death of millions of people worldwide. It is particularly important that we know about telemedicine. All of you are familiar with the media. You know that in Chitra Tirunal, in Wockhardt Hospital, Delhi, several hospitals in Bombay, several hospitals in Delhi, Indore, etc. Because healthcare providers were tested corona positive, hospitals had to be closed. When I was a medical student in the late 60s and early 70s, this was how the wards were as a routine. Today, we almost never see a ward like this. Unfortunately, with the pandemic, if the pandemic really comes into picture, which we are all praying it will not happen, this is what hospitals in India will look like. Now, when this happens, because of the contagious and infectious process, doctors have to be isolated. Healthcare providers have to be isolated. Now, remember that a doctor may be isolated, but he continues to be mentally and physically in top form. A doctor isolated, quarantined from the comfort of his home, if you provide him with the technology, can oversee at least 100 or even 150 patients. Worldwide, telemedicine has been advocated, whether it is China, Hong Kong, Australia, you name it, every single country, most countries, out of the 197 countries listed as being corona positive, more than 75% have notified. Our own Prime Minister mentions telemedicine every time he addresses not only the nation, but when he addresses other important organizations. World Health Organization, CDC, have again and again said that telemedicine is the best way to handle this crisis. Trump, when he allotted $4.3 billion the first time, set apart $500 million exclusively for telemedicine consultations. You all know that the United States, they're paranoid about HIPAA regulations. Every one of them have been thrown to the winds, and all the rules and regulations have been changed in order to handle the corona pandemic. Insurance companies today, every single insurance company in the United States is now reimbursing telephone calls, not a formal video consultation, but even a telephone call. They have codified it, less than 10 minutes, 10 to 20 minutes, more than 20 minutes, and so on. I, as a telemedicine evangelist, as a telemedicine enthusiast, I feel sorry that this happened because of COVID-19, but I am absolutely amazed by the response which we are getting from all over the country. Every day, we have several WhatsApp groups where telemedicine enthusiasts are joined together, and at least 5 to 6 I've been getting every day for the last 30 days. Free teleconsultation, whether it is NIMHANS, All India Institute, Chitra Tirunal, SGPGI, Apollo Hospitals, SRMC, you name it, every single hospital today has got onto the bandwagon. Appeals have been made to doctors from various chief ministers saying, please provide remote consultation. Now let's go into the real world. We are all taught that COVID-19, the presentation is fever, sore throat, temperature, difficulty in breathing. Of course, as specialists, we know that there are other manifestations also, but right now let's take these 4. Every one of this can be tested without a paramedic, without a nurse, without even a healthcare assistant or a doctor physically in front of the patient. The apartment complex where I live, they have got an infrared scanner. Anybody comes out to the apartment, goes into the apartment via scan, our temperature is recorded. Bluetooth enabled, this can be transmitted to anybody. The pictures are self-explanatory. You see how it is not at all necessary to be in front of somebody to examine his throat. And robots are already available in China, in other countries. Robots in India have already been started. To the best of my knowledge, I have not yet started taking a throat swab, but in China, robots take a throat swab. Blood for examination, blood testing can also be done by a machine controlled by a human being. Stethoscopes, these were available long before the COVID-19. It is a reluctance on the part of the medical profession. For ever since Count Laennec invented the stethoscope, somehow we have all got so addicted. We wear a stethoscope around our neck, even when you go to a movie theater or when you give a lecture or appear in a TV. I've always been fascinated why a doctor should wear a stethoscope when he's giving a TV interview. Anyhow, that's by the way. Today's stethoscope is like this, Bluetooth enabled, very small, with like an ECG. A stethoscope also can give you a semi-automated diagnosis. It can tell you RALS, bronchitis, third heart sound, fourth heart sound, whatever you want. Pulse oximeter, 12-lead ECG, ultrasound, every one of these are truly mobile. I'm now going to the second part of my talk, which is the Board of Governors in supersession of the Medical Council of India have notified on March 25th the guidelines. I want to start off with a very good news for you. Unfortunately, in the last 22 years, I do not know why, every talk which I've been giving in the last 2 decades, there's a question, what are the medico-legal implications? I just don't know why we are also paranoid about medico-legal implications. There has not been a single instance in India, in a consumer protection forum or in a court, where any patient has gone with a telemedicine issue as a complaint. The United States of America, all of us know, are primarily a litigious society. Even there, less than 2% of all cases filed in US courts relate to telemedicine. Now, with that background, I want to reiterate that today the Epidemic Diseases Act 1897 and the Disaster Management Act 2005 have been notified not only by the central government but by all state governments. Now, what does this act say? It says, I repeat, no suit or other legal proceeding shall lie against any person, please understand, any person, not just a doctor, for anything done or in good faith intended to be done under this act. If you make a genuine mistake, so long as there is no mala fide, so long as there is no deliberate attempt, no doctor will ever do anything deliberately. It may be an error in judgment. So long as it is done in good faith, so long as you accidentally overlook something, so long as the Epidemic Act and the Disaster Management Act is not denotified, you are totally immune. Nobody can do anything, can take you to court when these two acts are working. To me, March 24, 2000 was a red letter day. It was on that day that formal telemedicine unit was commenced in the whole of South Asia. Bill Clinton, the then president, formally commissioned the world's first VSAT-enabled village hospital in Aragonda, the birthplace of Dr. Pratap Reddy, founder chairman of Apollo Group. This was an ISRO-mediated VSAT, which ISRO gave us. I don't know whether it's a coincidence, but exactly 20 years, 24 hours later, the Board of Governors notified an amendment to the Indian Medical Council Act 3.8.1, which says that consultation through telemedicine by the RMP shall be permissible in accordance with the telemedicine practice guidelines contained in Appendix 5 and so on. I have, in the last couple of years, reviewed practice guidelines of many organizations, including that of several states in the United States, Malaysia, Abu Dhabi, etc., etc. Malaysian government was the first to introduce this as early as 1997. And there, a doctor who does something against the guidelines can be imprisoned up to 5 years. In Abu Dhabi, it is illegal for a patient, meaning any citizen of Abu Dhabi, it is illegal for them to even seek a teleconsultation with a doctor who is not registered under the Abu Dhabi Health Board. You and I, irrespective of our competence and professional qualifications, unless we are registered with Abu Dhabi Health Board, we cannot give a teleconsultation. When you compare all this, I find that what has been notified by the Ministry of Health, Government of India, is the most doctor-friendly, at the same time takes into account patient safeguards as well. Now, when a patient comes to you for a consultation, a face-to-face consultation, none of us take a consent. It's an implied consent. And when he comes to you, it is implied that you can do even a rectal examination, a vaginal examination, a throat examination. You can take venous blood for blood test, a chest x-ray, a CT scan, and so on. Of course, you may require a consent if you're doing an intra-arterial injection, or even ultrasounds generally do not require a consent. Similarly, in a telemedicine practice, if the patient initiates the request for a teleconsultation, it could be through somebody, but so long as a patient wanted the teleconsultation, or you, the doctor, wanted to review one of your old patients, the consent is implied. You do not need to get another consent. However, the government has been, of course, incidentally, it was the Telemedicine Society of India. I am a past president of the society. Several of us, particularly the present office bearers, for the last 2 years, we did a lot of work on this, and this has been pending with Niti Aayog and several other ministries. Thanks to COVID-19, of course, it was accelerated and put on fast track mode. Now, the practice guidelines clearly indicate a first consult and a follow-up consult. And the guidelines very clearly say that a first consult should be at least a video consult, meaning that the rules prohibit you from prescribing certain medicines through a telephonic consultation. Of course, certain drugs are allowed, and particularly in the epidemic time, they are allowed. But generally speaking, the first consultation should not be a telephone consultation. Now, having said that, there is no cannot, should not, will not, be not, nothing like that. It is entirely depends on the context. What when telemedicine is absolutely contraindicated for a fresh MBBS in a tier 2 or a tier 3 city or a small town, for a person like me, a super specialist working in one of the leading hospitals in the country, a quaternary care hospital with all the technology and resources at his command, I may do a teleconsultation, but that doesn't mean that I'm right, or it doesn't mean the other guy is wrong. So it is a context. The context alone is important. The present rules permit a teleconsultant to give an opinion to a caregiver to a patient who, because of his physical or mental condition, is not in a position to physically come in front of the camera, or you are not able to take the camera where the patient is. Again, you are authorized to discuss about the patient's condition to a health worker. Of course, second opinions are allowed, or a registered medical practitioner to another RMP or to a specialist. During the first 15 years of my career in telemedicine, I used to say, I now feel so, how could I have made such a big mistake? I used to say that by definition, telemedicine excludes emergency. But 5 years ago, I started eating my own words. Technology changed, culture changed, everything changed, and I proved that I was wrong. Today, as I told you, we run the largest emergency medical services. The practice guidelines clearly indicate that you can give a teleconsultation for an emergency, but it specifies unambiguously that it is the doctor's responsibility to cater only to the emergency component of the clinical problem, and immediately after your advice has been given, you must advise the patient to physically go for a face-to-face consultation with the nearest possible appropriate doctor. This is very important. Now, again, a few things can happen. See, it's very difficult for somebody who's not practicing telemedicine to understand this. When you come to see me in the hospital, you assume that since I have a consulting room in a quaternary care hospital, you assume that the hospital medical superintendent has done all the credentialing, that I do, I'm genuine, that I do have a degree, that I'm a registered medical practitioner, etc., etc. You do not go into my bona fide. Whereas in a teleconsultation, impersonation could happen at both ends. Impersonation could be happen at the medical end, at the doctor's end, can also happen at the patient's end. Therefore, the guidelines insist that I'll show you a demonstration in a few minutes, insist that your name, your qualifications, your registration number, my 26075, Tamil Nadu Medical Council, consultant neurosurgeon, Apollo Hospitals, my qualification, all that be displayed on the screen during the period of teleconsultation, so with my photograph, so that the patient knows that he is indeed talking to a person who claims to be what he is. Similarly, it is assumed that particularly in a first consultation, that you have satisfied yourself. An Aadhaar card, a photo ID card, driving license, passport, whatever you want. The government doesn't specify which. Satisfy yourself that you are indeed talking to the person whose CT scan reports, whose blood sugar reports, etc., etc. You are actually evaluating this. Now, a concern which many doctors had was whether a doctor in Tamil Nadu can see a patient virtually in Assam or in West Bengal. This guidelines unequivocally state that a doctor registered under any state medical council can practice telemedicine in any other state. However, nothing is mentioned whether, it doesn't say it's illegal, but nothing is mentioned whether a doctor can see a patient outside India, or whether a patient outside India can seek my consultation. In case you think this was a typographical error, it is not. Clinical judgment, clinical judgment, clinical judgment. This is the name of the game. The practice guidelines expect you to exercise the best professional judgment. I am a senior citizen with white hair. I belong to the old school. There was no ultrasound at all when I even got my postgraduate degree. So if I was suspecting a case of prostatic enlargement from teleconsultation, I would not be comfortable without doing a rectal exam. And therefore, I would tell the patient, sorry, I cannot proceed further. Please come to me or go to some other doctor. You do need a rectal exam. However, a just qualified MS MCH who has been trained in the ultrasound era, he may be very familiar with the pelvic ultrasound, and to him, the ultrasound may give every bit of information with his index finger may give, and he may say, I don't need a rectal exam. I don't even need a rectal exam to diagnose piles or hemorrhoids. This is enough for me. That's fine. So this is what I mean by clinical examination. Use your judgment. Every case has to be tailor-made, customized to suit the context under which you are doing the teleconsultation. Now, I got this patient about 2 years ago. He came to my consulting room. The patient didn't come. The relatives came. They brought a CT scan. They said the patient is in a town. He cannot be shifted. And the CT scan showed mild hydrocephalus, encephalomalacia, and so on. And as I told you, I am an old-fashioned doctor. I never treat images. I treat human beings. So I said, I'm sorry, I must see the patient. And I was very pleasantly surprised when he himself said, sir, can I show you the patient on a mobile phone? I said, that's fine. And with an ordinary phone, not a smartphone, very ordinary phone, the relatives there, you can see here, this is all the information that I need. You need to tailor make, you need to customize. Obviously, I don't want to do a perianal anesthesia. I don't want to look at Babinski. I don't want to look whether he's got hyperreflexia or not. I don't want to look at his fundus. All I want to know is what are his activities of daily life? What is it that he can do himself? What is it he can't do? I definitely need to know because he's on a right tube, whether he's got a 9th and 10th nerve paralysis. So I need to customize my examination to the clinical picture. When I am confident that it can be done remotely, I go ahead. Another example, though I'm showing these examples, okay, I'm biased because I'm a neurologist, neurosurgeon, but you can extrapolate this to a general medical practice, to a cardiology practice, or whatever you're practicing. This was a 12-year-old boy from Dubai whom I did a teleconsultation. The mother gave me a history which was strongly suggestive of seizures. However, examination, as expected, had no neurological deficit. CT scan done in Dubai was normal. EEG done in Dubai was normal. I refused to put the boy on anticonvulsants. I said, nothing is going to happen if he gets another fit. Wait for him to get another fit. And when he gets another fit, just take your mobile phone, take a photograph, take a video of everything and send the video to me. Now, this is a classic example. A good third-year MBBS student should be able to diagnose this. He does not have grand mal, he does not have tonic-clonic seizures, but I have got all the information I want. Therefore, you need to use your judgment. Please remember, it is as wrong to make an over-diagnosis. I don't want to miss a seizure, but at the same time, it's criminal on my part if I put somebody on for a lifetime or for several years on anticonvulsants. So please use your clinical judgment on what is to be done. This is a patient whom I saw just 4 days ago or 5 days ago, lockdown period. Now, you can see on the top left, of course, I made this only after the practices rules are allowed. Let me be honest. You can see my photograph, my name, my qualifications, the council in which I'm registered, etc. Permission obtained from so-and-so to record video of the teleconsultation and use it without revealing identity. I've written the prescription on my letterhead and I've made the diagnosis. The MCI regulations, particularly for teleconsultations, you must put the diagnosis. Diagnosis need not be a complete diagnosis. Obviously, the patient has come to you for a diagnosis. Now, in this case, it is a follow-up. So I've written there, diagnosis, right-sided, trigeminal schwannoma, cyberknife irradiation, October 2019. Now, she reported to me on the phone and I said, I will not give a consultation on the phone. I must do a video examination. It was not a classical trigeminal neuralgia, paroxysmal, intermittent, sharp, lancinating, etc. It was more an atypical hemifacial pain. Now, again, it was 9 months since the cyberknife radiation was done. This was not the time when you get post-radiation edema. I was not very sure of the diagnosis, but taking into account that she was in Bangalore, lockdown period, etc., I just put her on carbamazepine. I did not write tegretol, mazatol, zeptol, etc. I put carbamazepine, 100 milligrams, 1 at 8 a.m., 100 milligrams, 1 at 8 p.m. Telephonic review after 10 days. Call. My signature, my JPEG image, registration number. I took a photograph of this through my phone, sent it to her as a WhatsApp. She in turn showed this. I do a relevant, customized neurological examination. I want to know whether she's got trigeminal anesthesia or not. Obviously, is no facial. She had no other neurological deficit. And in my prescription, I've written fundus not examined. Based on my clinical experience, I do not think it is ICT, and therefore I proceeded even though I did not examine the fundus. So this is what you need to customize it. Again, lockdown period. Again, a person whom I saw just 3 days ago. Again, in the Himachal Pradesh, in a small little town, 75-year-old diabetic, hypertensive, myocardial infarction on anticoagulants, warfarin. I can't do INR. I cannot do that and this, etc. You need clinical judgment. Acute subdural hematoma, drug-induced subdural hematoma. 2 burr holes were done in a military hospital. Ideally, the patient should have had a craniotomy, but because of the COVID-19 situation, they were also unable to do it. The patient was brought back home. Now, a clinician is what is required here, not a technician. You don't require somebody with a lot of theoretical knowledge. It's a few days since I saw him. I again kept in touch of him. The patient is slowly getting better, but I know it's going to take many months before it. I have documented everything. I have written in my records that under the circumstances, A, B, C, D, E, even though the post-operative CT scan still shows a mass effect, in my opinion, the risk of aggressive treatment today in the lockdown period and is being exposed to the coronavirus in a hospital where there has already been a positive case is much more than treating him conservatively. Nobody can question my judgment. It may be a wrong judgment, yes, but it has been done for the right purpose with the patient's interest primarily and done in good faith. Anything done in good faith cannot be taken to task. Now, the doctor has to maintain at least the same standard of care during a consultation as in a face-to-face consultation. Now, again, the present rules allow you to interact with a caregiver, as I did in the slide before. See, that person is conscious, but is drowsy. He talks Himachali. He doesn't even talk Hindi. So language could be a problem, particularly in teleconsultations. You must have a translator. You must have somebody who can communicate with you. Luckily, his wife, the elderly lady, speaks Hindi, and I know enough Hindi to be able to communicate with him. So compliance, adherence, documentation. Again, in FAQs, I've given several webinars in the last 1 week. Sometimes I'm asked, can you charge fees? Of course you can charge fees. The guidelines only suggest that the fees should be similar to a face-to-face consultation. Whatever fees you charge, how you collect the fees, when you charge, when you collect it, this is entirely your individual prerogative. A receipt or invoice should be sent. How you send the receipt, all that is entirely your prerogative. No guidelines have been given for that. Questions are often asked about maintenance of records. The government hopes, and we also hope, that in a question of time, maybe 1 year, maybe 2 years, maybe 3 years, every doctor, at least MDs and DMs and MCHs, at least people like us, we do start practicing EMR. We start using electronic medical record, electronic health record, and MPHR, mobile personal health record, and so on. It's in our own interest that we do it, because here everything is there. It's a drop-down menu, drag and drop. It may be a little difficult to get accustomed to it, but after that, it doesn't take you more than 2-3 minutes to fill up all the information given. Till such time as you have that, I strongly suggest just have a small notes, bullet points. Nobody wants you to write the deep tendon, the brisk biceps, triceps, perianal anesthesia, that thing, this thing. Nothing nothing. You don't even have to mention about reflexes. Just say left hemiparesis 3/5. That's all that is required. Use your judgment again in whatever clinical finding is relevant to the diagnosis. This is not an academic exercise. You're not taking classes for postgraduate students. Just mention whatever you think is relevant. Now, investigations have been done. I'm not going to mention all the normal investigations. I'm just going to mention HbA1c 7.2 bracket 8.24 weeks ago. So you use your judgment and decide on what is to be recorded in the case sheet. There are several pages in the practice guidelines about prescription. I don't want to complicate it further. It's really not complicated. For practical purposes, don't get into a digital signature. A digital signature is class 1, class 2, class 3. It's an encrypted signature which can be obtained only from authorized companies, etc. For the present purposes, the government says it is enough to write an ordinary prescription, put your signature, and scan your prescription, or take a photograph of your prescription with your mobile phone and then send it. That is enough. An electronic prescription is different from an e-prescription, and that's just to make it complicated. You have an ordinary prescription, send it electronically. Every pharmacist is duty bound. He cannot, after March 25th, insist on a paper prescription and a prescription shown to him on a phone, on a WhatsApp, laptop, or a tablet, what have you, is enough. Of course, having said this, the government is very clear. They have divided it into OTC and other groups. I'll come to that in a minute. Certain drugs cannot be prescribed. Schedule X, you cannot obviously prescribe nicotine, pethidine, psychotropic drugs. There are a lot of changes which need to be made. We have already got feedback in the last 2 weeks, and the Telemedicine Society of India will be in constant communication with the Board of Governors. The Board of Governors have already given the first amendment. It is amazing. And I want the help of all you people. Please help us, because no single doctor knows about all the medication. I request cardiologists in your group. The Psychiatrists Society of India had already made a representation, and it's amazing how within 10 days, the Board of Governors have accepted it. They've included medicines suggested by the Psychiatric Society of India. Similarly, please remember that Rome was not built in a day. Nothing is made of stone. It's going to take time, and the circumstances under which this is done, you must really appreciate the fantastic work which the Ministry of Health is now doing. With all their problems, they're still attending to this. So these prescriptions are there. Again, I am assuming that every one of us has maturity. We have clinical wisdom. Now, just because it's a teleconsultation does not prevent you or does not absolve you of a mistake you make if you did not ask whether that young lady probably is pregnant or could have become pregnant. History is absolutely essential. When I prescribe anticonvulsants, I assume that I have the basic knowledge to examine liver function tests, renal function tests if necessary, drug interaction, and so on and so forth. All this has to be taken into account. Specific guidelines have been given. This is what is recommended. The Medical Council of India, basically, it just says name, address, age, sex. I don't think you need to bother about height, weight, and all that. But prescription, provisional diagnosis is required. Now, from a telemedicine pundit's point of view, there are major exclusions in the practice guidelines. The exclusions are being done not because the government is not aware of it. It will be taken up in the next setting because of the urgency. There have been no specifications whatsoever of hardware, software, infrastructure building, maintenance, data management systems, their standards, interoperability. Now, this is a huge project, a UHID number for every citizen of India, an Aadhaar card whose health functions can also be denied. I dream of the day in my lifetime when I take an X-ray in a primary health center in some outskirt of Tamil Nadu, and 5 days later, when I'm in the All India Institute of Medical Science Neurosurgery Department, by clicking a button, he will be able to see the X-ray. Ideas have already started. It's going to take many, many years, but certainly it is going to happen. Now, again, one of the important exclusion criteria is digital technology cannot be used to conduct surgical or invasive procedures remotely. Last year, the media flashed news about a cardiologist, an invasive cardiologist in Gujarat, who remotely carried out an angioplasty. Such procedures cannot be allowed, will not be allowed. Robotic radiosurgery, you can telementor, you can guide through video a surgeon there, but you cannot remotely give an order which is technically feasible today. You cannot control a robot unless you're physically present in the presence of the robot. So these are some of the guidelines which are made. The second part of my talk, I would like to conclude maybe on a little emotional way, that it is March 25th, 2020 is really a red letter day for those of us who have been trained in the BC era. The notification of TMG marks the dawn of a new era in the practice of modern medicine. 10 years from now, perhaps face-to-face visits will be the exception and not the rule. All over the world, there has been a dramatic change, particularly in the last couple of months. I'm writing an article, a couple of articles, and so I've been reading the literature. 28 articles in the Journal of Neurosurgery, Surgical Neurology, etc., which I read. Every single article talks about tele-rounding, education of residents. How are you going to train residents in various specialties where social distancing is going to be the norm? So whether you like it or not, ladies and gentlemen, remote healthcare will be the new normal. Again, the government has specified that AI has already been used by many of the corporate hospitals. Google is actively working with Arvind Eye Hospital. We have also just started using AI in some of the areas. So diabetic retinopathy and so on. The guidelines very clearly state you can use AI as a clinical decision support system, but not in lieu of. You and you alone will primarily be responsible for whatever happens when you use an AI as things stand today. Remember that even a 5-bench Supreme Court judgment is being reviewed. Interpretations differ. You need a test case. These are only guidelines. The law is an ass. The law has to be interpreted. We all know how a district court's interpretation is overruled by a high court, overruled by a 1-bench Supreme Court, and so on and so forth. Therefore, there has not been a single case which has come to court in remote healthcare in the last 22 years. So please do not get paranoid about possible medico-legal sequences. Just go ahead and do what you think is right. Again, I would like to mention that not a single case has been filed. May not be not a single case, I'm exaggerating. 98% of cases, suo moto, very few organizations take notice of a so-called malpractice. Cases go to court because the doctor-patient relationship is so horrible. You have annoyed the patient, you have made him angry, you have irritated him. The patient does not go to court because of adverse results. You empathize with the patient, you sympathize with the patient, you identify yourself with the patient. And in case you think that telemedicine takes away all this, you're totally wrong. The more the technology you use, the more you should stick to TLC, tender loving care. In my experience of having given about 2,500 neurological consultations in the last 17, 18 odd years, I get the impression that the patient at the other end, he may be a school dropout, but in 100 seconds, he will knows your body language. He knows exactly whether you are really concentrating on him, whether you are really hearing what he is saying, whether you have been able to identify yourself with him. That, ladies and gentlemen, is what is much more important, not all the technology at your command. Technology is a means to achieve an end. It is an enabler, never ever an end by itself. Telemedicine has got limitations. Telemedicine has got advantages. It has got disadvantages. We expect you to exercise your maturity, your clinical judgment, your clinical wisdom, and decide on whether for that particular case, on that particular day, on that particular time, for you and the patient, telemedicine is indicated or not. It was Winston Churchill who said during the Second World War, never ever let a good crisis go to waste. The world has woken up from slumber. I don't think coronavirus is going to beat us. 7.3 billion people on this planet. No way. Maybe a couple of months, our life is going to get dislocated. But we are going to come back as a victor, not just beating the coronavirus, but saving the whole planet. The journey of 1,000 miles begins with one step. That's what Confucius said. This is not the first step. The first step was taken 22 years ago. We probably have traveled several miles, but now, to quote ISRO, which incidentally played a major part in the development of telemedicine initially, we are reaching that critical mass essential for a successful takeoff. Unless there is a critical mass of doctors, unless thousands of doctors understand and accept that telemedicine is not only in the interest of their patient, but is in their own selfish interest, telemedicine will continue to be on the outskirts and never be embraced to become an integral part of the healthcare delivery system. I know you people must be feeling bored. So anyhow, don't worry. One of the advantages of remote virtual consultation is I won't even know whether you're sleeping or snoring or what you're doing. So just a few more minutes. I'm now going to concentrate. What I think is probably even more important, my previous webinars have never been to a group of consultant physicians and cardiologists. You people, ladies and gentlemen, are going to be the single most important group. Neurosurgeons like me, our role in the coronavirus epidemic is only to look after non-coronavirus neurological cases, protecting ourselves, etc. But you are the people who are going to make all the difference. I'm going to spend a few minutes. I'm sure all of you know about it, but I'm just going to repeat it to remind ourselves. I downloaded this slide just a few hours ago, and by now it should have reached 3 million. 3 million patients already coronavirus. The number of deaths have already reached 203,000. India, by God's grace, at the moment is way down, but we don't know. We cannot afford to be complacent as yet. In a few months, COVID-19 has transformed life on what is normally, in spite of terrorist activities, a very, very peaceful planet. This exponential disruption is not because of the virus biology per se. It is a consequence, a secondary effect of the massive global measures taken to contain the rapid spread. The global economy is going for a toss, and unfortunately, it appears that we are in no way anywhere near recovering, whether it is economy or whether it is a virus. How is telemedicine going to be employed now, immediately, in the management of COVID-19? Again, I am a fantastic admirer of the government. Which government will be able to bring out screening forms almost on a daily basis? They are changing the screening forms every few days. Weightage given is being changed. It is being customized, whether it's a hot spot, a red spot, green, orange, yellow, whatever you call it, etc. Now, you do not have to be a PhD in virology to be able to fill up this form. An ASHA, a digitally literate, tablet-empowered ASHA, and there are tens of thousands of these people, basic health workers all over the 700,000 districts, villages in India. These people can, even remotely with a telephone, call the people, fill up this chart, and instantaneously this is stored into the cloud. The government of India is able to get reliable statistics, and big data analysis is done based on which public health specialists and epidemiologists will decide on what is good for the country. So all this requires enormous amount of technology. Imagine if thousands of people could be given time-specific appointments scheduled in the nearest laboratory. Through a video consultation, I decide that you have a slightly increased risk and therefore it's worthwhile doing a blood test, or we need to take a swab from your throat or whatever it is. Instead of 2,000 people coming to Government General Hospital and waiting in the OP for them to be called, I give you an appointment at 10:10, 10:20, 10:30, and so on your mobile phone, and you report there 10 minutes earlier. All this is eminently doable. The results of the lab tests are communicated electronically to you, and symptomatic treatment initiated using an e-prescription. Perhaps a paradox, but it's a fact that the real treatment of COVID-19 is to keep sick people out of hospitals. Only the very sick need to come to the hospital, and therefore telemedicine is a safety valve for a strained healthcare system. Virtual visits is a very effective way to decide who needs to be tested for COVID-19. And again, telemedicine provides consultation for normal health issues. Please remember that just because the COVID-19 pandemic is present does not reduce my chance of getting acute appendicitis or getting a seizure, of getting a myocardial infarction or not. BBC, every news is announcing that they are afraid that people are not coming to the hospital for acute abdomen, for various other conditions because of the fear of being exposed to coronavirus. They still do not have statistics of the number of people who are dying of non-coronavirus infection related to a fear to come to the hospital. This should not happen in India. Please employ telemedicine. Let's say the worst thing happens. Let's say healthcare workers are isolated. A doctor who is isolated, prevented from physically examining a patient, is mentally and physically in top form. Sitting in his own house in his air-conditioned room with good connectivity, he can screen 50, 75, 100, 125 people per day. This is possible only if he understands, appreciates, and encompasses telemedicine. It is critical that COVID-19 suspected patients are not routinely referred to casualties or OP services. Respiratory clinics, you can have mobile vans. I understand some state governments have already started doing this. Mobile vans can be located in different places. Trained paramedical staff can be there. They can contact doctors. Doctors in turn, there may be an individual case where you want a second opinion. You can't expect a pulmonologist or an ID specialist to come all the way to where you are. Today, with a smartphone, you are able to interact with an ID specialist or a pulmonologist. So this is the future. This is what is going to be happening. Telehealth alone can be an effective alternative to in-person visits for patients. All this is fine when giving a talk. I mean, I could go on talking and talking for hours. However, it takes time to establish the necessary technology infrastructure. It takes time to recruit virtual providers, provide training on best practices, educate patients. You not only have to create an awareness among physicians and cardiologists, you also need to educate patients about telehealth through patient-facing websites, social media, direct outreach. At the end of the day, vitamin M does play a very important part. I'm always fond of saying that philanthropy at the best can initiate something. If you want it to be self-sustaining, it has to be revenue generating. I have seen hundreds of telemedicine centers being opened, what I call photo op opportunities. MLA, MP, minister comes, cuts the ribbon, photos announced all over the press. 6 months later, totally locked. Why? Because there is no money to pay the technician. There is the doctor, no money to pay the doctor. Please remember, it is not malpractice. That is not wrong for you to expect to be compensated for what you do. You doctors are a very powerful group of the people. You are the cream of the cream of the cream of society. I implore all of you to please talk to the insurance companies, ensure that the insurance companies in India recognize reimbursement for teleconsultation. It's in their own interest that they will do it so that crores of rupees are spent and complications are avoided. I've already covered all this. Fever, cough, shortness of breath can all be evaluated on a video. You have triage charts like this. All this makes it relatively simple for you to be able to diagnose. Now, when I was a medical student and a postgraduate, there was only one All India Institute of Medical Science and 5 IITs. Today, I understand there are about 18 AIIMS and about 22 IITs. Medical colleges, there were 100 medical colleges. After I made this slide, I think a few more have come, and the Medical Council of India website, which I went to 2-3 days ago, there were 534 medical colleges. Every 3 weeks in the pre-COVID-19 era, at least every 3 weeks, a medical college was coming up somewhere or other in India. When we can do this, ladies and gentlemen, why can't we have a good tertiary, quaternary level of telemedicine unit in at least 1,000 secondary and tertiary hospitals? I am looking forward to the day when the NABH inspector will ask whether you have an accredited telemedicine unit. The CEO of a hospital today wants an intraoperative MRI. He wants a cath lab. He wants stereotactic radiosurgery. He wants a 640 slice CT scan. Why don't you ask for a telemedicine unit? I am afraid that telemedicine will become a part of this country's healthcare system only when there is a political will. For the last couple of years, MLAs and MPs, when standing for election, have promised laptops, have promised that and this, etc. I look forward to the day when an MLA and MP standing for election says, in my constituency, I will ensure there are at least 10 telemedicine units. That day, India will become recognized as the world's leader in telemedicine. Today, in the institution which I'm privileged to be associated with, the Apollo Telehealth System, we are providing almost 9,000 to 10,000 consultations a day, most of this through public-private partnerships with several state governments. I could go on and on. I think I will stop here. If there are any questions, I'll be happy to take it. Before I sign off, this is as a past president to the Telemedicine Society of India, may I request every one of you interested in telemedicine, two things. A, please join the Telemedicine Society of India. We already have some suggestions from a few societies, and we are planning to have subgroups within the TSI. We'll be very happy to have, we now have state chapters, 14 state chapters. We will be very happy to have a group exclusively for physicians, a group for cardiologists, for neurologists, neurosurgeons, and so on and so forth. One. Two, the Medical Council of India has specifically asked the TSI to have an introductory orientation, sensitization online program. We were able to get about 140 volunteers who worked day and night for 2 weeks. They did an amazing job. Please remember, this is pro bono, not a single pie. People spent money out of their pockets. We have been able to get connectivity, we have been able to get platform time, etc. from the industry, but this can't go on and on. We will be giving free orientation till May 3rd. All the details are available at tsi.org.in, Telemedicine Society of India. Please spend 2.5 hours of your time on a Saturday or a Sunday morning, evening. All details are available there. It will be worth it. You are the people. The future of India lies in your hands. Please remember that I do not talk about India achieving world class. I used to talk about that 10 years ago. Today, I talk of in the world trying to achieve India class. I think we have reached that stage now. The world should try to achieve India class. You should not follow high standards. You should set them. Gone are the days when we used to follow high standards. In 2020, and the coronavirus has given us an opportunity, we should no longer follow high standards. We should set them. Thank you once again for giving me this opportunity.
I would like to thank Professor Ganapathy for such an enlightening and engaging talk. And I think we have been blessed to hear from the who's who in the field of telemedicine. And moving on to the Q&A session, I begin with a question, sir, for you on, are there any procedures set for registration of the doctors under the TSI to practice telemedicine? Is there any procedure for registration?
Yeah, the Medical Council of India guidelines have very clearly said, at the moment, there is no necessity. It is not mandatory or compulsory to re-register or to register. Any registered medical practitioner is by law authorized to practice telemedicine. However, he is given 3 years time. Within 3 years, he has to show evidence that he has successfully completed a course, which most likely the TSI will be authorized to implement that course. We have started working on it. That is going to take some time. However, the Medical Council of India has requested the TSI Now, this is not authority. I cannot force anybody, but the MCI has requested us to at least familiarize, orient, sensitize 500,000 doctors on what exactly to do, how do you do telemedicine. For this purpose, we have already started. We are doing a pilot now, proof of concept. About 2,000 doctors have taken this, and we have got feedback from them. We are modifying the course, everything. It's more or less ready now. It is ready. And as I said, I would once again entreat everybody who listened to this. The very fact you have listened to this webinar shows you have some interest. Please spend another 2.5 hours. It's very easy. You just have to go to the TSI website. It is free. Everything is free. A link is provided. Just click on the link and you will get directions on how to register.
Thank you, sir. And are there any softwares recommended by the Telemedicine Society of India for the doctors
Yes,
to
the
practice telemedicine?
Telemedicine Society of India, by definition, is a scientific, professional, not-for-profit society. We are agnostic. We have a 60-inch monitor. The bigger, the more data from the American Medical Association, American Telemedicine Association, European Association, published literature in JAMA, New England Journal of Medicine, Lancet, the world's most respected journals, etc. And we provided enough evidence that in 2020, 2019 to be precise, last year, telemedicine is as good or better than face-to-face consultation on certain specific issues. The Karnataka Medical Council magnanimously said, yes, we were not fully informed. The information given to us, we took a decision based on information given to us. See, it's like a court. In a court, we know several benches have overruled the decision because information provided. A judge gives an opinion based on information provided to him. If the information provided to a judge is incomplete, obviously you can't blame the judge. So we really hope that the IMA national president will look at all the data available. We would be more than happy. In fact, I would like to use this forum that many people listening. We would be more than happy to meet him either virtually or physically, virtually obviously, and explain to him what it is so that he understands the implications of the IMA not supporting telemedicine and the implications of IMA supporting telemedicine.
Let's hope that it gets resolved very quickly. Coming on to the next question, I just wanted to know, because there is a question on this, that are there certain recommendations from MCI that you cannot do telemedicine or do teleconsultation in the age group less than 18? Are there any such recommendations from MCI?
Absolutely none. The MCI says in the medical practice guidelines as applicable in any law. Forget the use of technology. Forget use of technology. What do you do when a 15-year-old comes to you for a consultation? As per the law, I cannot physically lay my hands on anybody less than 18 years old without the parent or the legal, whoever it is, father, grandfather, uncle, whatever it is, somebody has to be present. You are an adult, only you are allowed to vote only after you become 18. Below 18, you are a minor. It has got nothing to do with telemedicine. So in telemedicine is concerned, you can certainly do an examination of a newborn baby or a 1 year. I have done hundreds of examinations of children with neurological problems. The parents were there, the grandparents were there, the uncle was there, the aunt was there. I don't expect a 9-year-old boy to be smart enough to ask for a teleconsultation on his own. If he does, you are absolutely right. I cannot give the consultation.
Right. Now, are there certain lists given by Telemedicine Society of India for the drugs which can be prescribed through teleconsultation? Is there some list of drugs?
No, the Telemedicine Society of India is like the IMA or any other association, a professional society of like-minded people. We do not have the authority to give a list of drugs. We are only a facilitator requesting the MCI to modify the drug. The entire list of drugs is available in the Ministry of Health and Welfare. It's on the home page. It's so easy to get it. Just ask the attendees to type out mohfp.in, and the very home page you will find new flashing telemedicine guidelines. Click onto that I don't remember the page number, 25 or 26 or something. Everything is given in detail.
Right. Since we're talking about drugs, let us talk about the psychotropic drugs, because I think, can we prescribe those psychotropic drugs to an individual through teleconsult? First question. And the follow-up question is that if a patient is already on a psychotropic medication, can he be given the same prescription for a follow-up?
Yes, a very good question. The very first consultation, a psychotropic drug, it is recommended should be a face-to-face consultation. However, a video consultation, you can prescribe some drugs. Now, as per the original March 25th notification, psychotropic drugs were not allowed. However, the Psychiatric Society of India had made some representations, and I think very quickly the MCI has accepted it. They have given me, they have given, no, sorry, not me. They have notified an amendment. Some psychotropic drugs can be prescribed by a qualified psychiatrist under certain conditions. So far as refills are concerned, yes, refills are allowed of certain drugs. I cannot give you the entire list of drugs. One, I don't know. I don't need to know. All this information is available in the MOH website.
Right. Since we are talking about the teleconsultation, let's talk about the tele-prescription per se. What you have already deliberated about it in your talk, but sir, could you please brief us on what should be the ideal structure of a tele-prescription?
It's very simple, sir. Whatever is your normal prescription, just for why are we making life so complicated? An ordinary prescription in your ordinary letterhead with an ordinary pen. What do you do? I mean, when I used to write prescriptions, I honestly would not write the diagnosis. I only wrote the name, age, sex. I would write the pharmacological generic name, the trade name, how it is to be taken before food, after food, one in the morning, afternoon, evening, etc., etc. Now the MCI insists not only for a teleconsultation, but for any consultation, the diagnosis must be written. So you must write the diagnosis. Now, for a teleconsultation, most of the time I may not have made the diagnosis. That's fine. I just have to write a working diagnosis. For example, as a neurosurgeon, I will write NYD headache, not yet diagnosed headache, which very clearly says I do not know what is the cause of the headache. Or I may confidently write tension headache, meaning it's a muscle contraction headache or a psychosomatic headache. So I write that. Now, I must write that because when I write that, it is implied that I have excluded serious causes of headache like meningitis, like a hemorrhage inside the brain, like a brain tumor, and so on and so forth. So now, for example, acute abdomen. It is wrong to give antispasmodics for an acute abdomen through a teleconsultation because the acute abdomen could be due to an acute appendicitis, could be due to so many other surgical conditions. So you must write down your working diagnosis. That is all the prescription states. And the duration, 10 days, 2 weeks, 3 weeks to be taken before food, all list out all the drugs, etc., etc. Having done that, today every single doctor, I bet there's not a single doctor in the world who does not have a phone. 90%, 99% of patients have a phone. Just take out your phone and then click, take a photograph of it. It is stored in gallery or whatever it is, and then send it as a WhatsApp to your patient, or send it as an attachment, or send it as an email, whatever way you want, or scan it. If scanning is easier for you, if your secretary will do it, ask your secretary to scan it and then send it. Send it to the patient. Now, you cannot send it to a pharmacist of your choice or any pharmacist without the consent of the patient. So, in the prescription form, you will write, copy of this prescription is sent to pharmacy ABC with as per instructions from the patient or with the consent of the patient. Write that down in the prescription. That is all. And take a photograph. And this photograph, of course, has to be stored. You can't delete it. So you must preserve the digital prescription in your records for a minimum period of 3 years.
I think we have answered the query on medical records, because that is the question which I was going to ask. What constitutes medical records in teleconsultation? You've already told probably we need to store the PIC for 3 years, right, sir?
Yeah.
Okay, now talking about consent, what is the ideal way to take a consent during a teleconsult? Do we
No,
need to
you
involve,
do
yeah,
you do not require a specific consult. I told you again and again, this is an implied consult. When a see, normally when a person calls me, calls my secretary, asks for an appointment, my secretary says 4:30 in the evening. I'm in my chamber. Patient comes at 4:25. I see the patient. I do not get the consent form from a patient just to listen to the story, history, physical examination, and investigate the patient. It is an implied consent. So, similarly, for a teleconsultation, no consent is required. However, if I am not going to see the patient remotely, virtually, on my screen due to some very special conditions, and I am interacting with the healthcare provider. The healthcare provider could be a relative, caregiver, sorry, correct term is caregiver, not healthcare provider. If I am interacting with the caregiver, who could be a nurse, who could be a ward boy, who could be a relative, anybody, I need to satisfy myself that the surrogate party with whom I'm interacting, namely the caregiver, is genuine and that the patient has authorized the caregiver to interact with me. I just need to satisfy myself. I don't need a 10 rupee stamp paper with the witnesses signing, nothing, nothing. I write down in my record, I write down interaction is with Mr. So and so, so and so, who is the uncle of so and so, or who is the son or brother or father, whatever it is, relative, or who's an employed nurse for the patient. Patient is not in a position to interact directly with me, either due to physical impairment or because of cognitive impairment, etc., etc. And therefore, I am interacting with so and so. I have been told by so and so that he is the authorized to this thing. That is all.
right? Coming to the mode of payment a doctor should use for taking the fees from the patient. What is the ideal way of taking payments from the doctors, from the
What is the
patients?
what is the ideal menu you like to have for dinner, sir? It's like asking that question. You may be a vegetarian, I may be a non-vegetarian, etc., etc., etc. There's no such thing as ideal method. Please get away from that. Whatever method is convenient, most convenient for the doctor and the patient. I don't know. I have no idea. You may like a credit card, you may like a debit card, you may like, I'm not, see the young, I like the younger generation, I'm not very familiar with what is it called? Paytm. Google Paytm, Google Pay, and I must ask my grandson for all this. I honestly don't know. So Paytm, Google Pay, that you decide whatever way you want, and how much you charge is your prerogative. You charge whatever you want. Normally, it is expected you charge whatever you charge in a face-to-face encounter, and you decide how you are going to give the receipt. You send the receipt through SMS, through WhatsApp, through email, through some group. I don't know. All that is government doesn't tell you do like this, do like this, do like. Come on, those eras all gone. We don't want. Please don't even think of this. Please don't even suggest all this. Don't trouble until trouble troubles you.
Right. I think we have a very pertinent question from one of our doctors. During this current COVID-19 pandemic scenario, can a physician prescribe the COVID test online?
I was asked this question in a previous seminar which I gave. I wish I'd gone again and tried to find out the answer. Honestly, I am not totally competent to answer that question, but my way of thinking, I'll only tell you my way of thinking. There are so many tests. I don't know what test you are referring to: antigen test, antibody test, smear, a throat swab, that thing, this thing, this thing. One, two. Normally, forget COVID. Normally, when I prescribe a test, what is the purpose? The purpose is to confirm or establish or exclude a diagnosis. Now, if I confirm a diagnosis, normally it is my moral responsibility to follow up on that patient. And if I can handle it, I treat. After the test is over, I continue by treating the patient. If I am not competent or somebody else is more competent, I refer the patient to him. In the COVID-19 situation, where, please correct me if I'm wrong, there is no place for outpatient management. It's a notifiable disease. The law demands that you notify it. There are, yes, private sector has been approved. Private sector has been recognized and approved. So I don't see any sense in electronically asking for a COVID-19 test. If you think this patient needs a COVID-19 test, I would very strongly refer this patient to the appropriate public health authority rather than you take on the enormous responsibility. See, once you're asked for a test, it is morally, ethically your responsibility to follow up. And if the follow-up is positive and you are not aware of it or you have not informed the concerned people, it becomes very, very complicated. So personally, I wouldn't in the present realm ask for a COVID-19 test.
Thank you, sir. I think there has been a lot of talk on catering to emergency services during this COVID-19 scenario. Can a doctor or does a doctor have the right to refuse a teleconsult for an emergency situation?
Yes, absolutely. No doctor. There are both Supreme Court judgments in face-to-face encounters. See, whatever is applicable in a face-to-face encounter, forget the telemedicine component completely. No doctor can be forced to do anything emergency or non-emergency. It goes without saying.
Now, coming to the patients who are staying not in India but in different countries, can a doctor sitting in India offer his teleconsultancy to a patient sitting abroad? Is this legal?
Good, very good question. This has not been mentioned at all in the guideline practices. There is nothing which says it is legal, whereas consultation within India, it says it is legal. There is nothing which says it is not legal. So this is a dark area. We have noted down this point, and we will be bringing this to the notice of the authorities. But all this will take some time. Right now, they are more interested in COVID-19 than all this.
I think we've been talking so much about teleconsultation, telemedicine. Sir, in your opinion, are these guidelines going to stay or is it only for the COVID-19 period?
With 10,000% guarantee, let me tell everybody that this is an amendment to the Medical Council of India Act. It is a fifth amendment. It has not been notified under the Epidemic Act or the Pandemic, or the other two acts which I mentioned about. I repeat again and again and again, the coronavirus only accelerated the process of notification. This would have come even without this. Maybe it would have taken a few months more. Maybe it would have been a little more stricter, etc. This has got nothing to do with the Pandemic Act.
Right. Physical examination, auscultation forms such an important part of internal medicine practice. How can telemedicine come to the aid of a doctor for helping him in auscultation and for physical examination?
Right. Again, I'm telling you again and again that you use your judgment depending on the individual clinical problem. If you think that you are uncomfortable, you insist that you would like to palpate the size of the goiter. It depends from person to person. You see, you suspect a goiter, you want to palpate somebody here, then don't do a telemedicine consultation. The first consultation can be you do your see. I was taught percussion. I mean, I don't know. I'm too old-fashioned, and I don't deal with medical students. I have no idea whether percussion is taught now. But the world has changed completely. Auscultation also. What today we have the portable, small echocardiograms. We have digital stethoscopes. And this morning I was seeing a video where Maharashtra Doctors Association, somebody in YouTube, where the patient is told to put, which I have done it myself, patient is told to put a digital stethoscope on his chest, and through Bluetooth it is sent to a smartphone, and the doctor is hearing it at the other end. So the world is changing, concept is changing. If you still think that a palpation is required, obviously you need a face-to-face consultation. But I see having diagnosed mitral stenosis, mitral incompetence in a patient, okay, the first time you did it, you investigated him completely. I see no reason why 1 month later or 2 months later, when you normally will be doing a follow-up, I don't see any reason how that palpation is necessary for the second visit. Number two, now pedal edema, cardiac edema, somebody is in congestive cardiac failure. I can always look for pedal edema. What is the big thing? I ask the patient to press the dorsum of the foot and I can make out pitting edema. Why do you need a DM cardiology to diagnose pitting edema? Pulse rate, the dyspnea, difficulty in breathing, everything. See, the days of diagnosing anemia by lowering the conjunctiva, by looking at your fingers for cyanosis, which is what we were all taught in the late 60s. I honestly don't think that is going to be the future. Now, again, there's a wrong impression. Now that you mentioned it, the IMA letter mentioned that clinical medicine is very important. There was a terrible statement made there that you cannot examine gait. I would like to refute that completely. I have done a detailed neurological examination of more than 2,500 patients. Only thing I was not able to do was to examine the fundus, which I could have done, but I did not invest enough money in that to get it done. So you can do a detailed neurological examination. Our rheumatologist, one of my rheumatologists sees 60 to 70 patients, rheumatology patients on Sunday morning, from morning till evening, from all over India. First time they come and visit him. But why? See, when you are prescribing immunosuppressant drugs and so many other drugs, you obviously want to see the patient once in 2-3 months. Why should somebody come all the way again to see you? 95% of reviews can be done remotely.
Now, coming to the teleprescription part, are we, allowed to write the brand name on a teleprescription, or just a generic name would suffice?
Sir, forget the word tele, sir. I've been telling you again and again, tele is only an enabler. I honestly don't know. You are more competent than I am. I don't run a pharmaceutical company. You are more competent. Whatever a doctor does in a prescription, exactly the same thing in a tele prescription. There are no special rules. Same rules.
Can a doctor give a medical certificate via a teleconsult?
Again, that depends on the confidence of the doctor, on the competence of the doctor, the indication, what sort of certificate. See, medicine, sir, is not so simple. There are so many variables. You will have to individualize, customize to decide. Now, if I'm asked to give a certificate that this patient is HIV negative, obviously I will not give it. Now, if I am to give a certificate, it depends on what I want the certificate for.
Right. Coming to the verbal instructions which a doctor gives to the patient, do they come under the purview of teleconsult, or do we need to give a teleprescription every time?
Sorry, I'm not clear. I don't understand your question.
Okay, I'll come again. The verbal instructions given by a doctor to his patient, do they come under the purview of teleconsultation, or do we need to give a teleprescription every time?
What do you mean by tele-prescription? Prescription, in my understanding, is only drugs. It is not counseling. See, the practice guidelines very clearly talk about patient management, patient counseling, and prescription. So all doctors spend a few minutes with the patient telling him this is what will happen, natural history of the untreated condition, tell them do's and don'ts, etc., etc., etc. You don't have to record all that. That doesn't come under any of this thing at all. But I don't understand. A prescription is only drugs. A prescription does not include counseling and telling the patient what to do, what not to do, do lifestyle changes. I don't write all that in the prescription. I mean, walk 25 minutes a day, reduce your weight, put less oil in your food. This sort of things I don't think comes in a prescription.
I'm not aware how valid this question is, but we have a question that in few Supreme Court rulings, telediagnosis in teleprescriptions have been taken as an offense. Your take on this?
there were no practice guidelines issued. These Supreme Court judgments referred to were not after May 25th, 2021. Two, again, it's an interpretation. Three, the biggest mistake we make is none of us, including me. See, it's almost sexy, so to call, to to highlight something which is not necessarily the correct interpretation. I'm not aware of the particular thing they are referring to, but you need to go. See, I'm sure you read in the press, nobody gives an opinion without reading the entire 400-page report or the entire this thing. The particular circumstances under which a Supreme Court judge made a observation in a particular case does not mean it's extrapolated to everything. One. Two, there were no rules before March 25th. So I'm not bothered about that at all. And one, two, every court ruling has again and again and again said, whatever is done in good faith, whatever is done under the context, under the then prevailing circumstances, in your professional judgment, that intervention is in the interest of the patient. No judge is going to punish you for it.
I understand you have spoken, sir, that consent is not important for a teleconsultation. But
You're misquoting me. Sorry. I beg to differ. Please withdraw that statement. I vehemently object. You replay my record. I would never have made a statement like that. I said again and again and again that when a patient initiates the request for a teleconsultation, the consent is implied, and
right,
that a written consent is not required when and only when the patient initiates the request. Let me finish. I also said when a patient comes to a doctor for a face-to-face consultation, if he is above 18 years old, we do not require a consent. So a consent is there. The consent is an implied consent. I never ever said that a consent is not required for a teleconsultation.
I
Please.
take my words back. The question is, can we have an audio consent for more clarity? Can a physician take an audio consent for more safety?
If you are paranoid about safety, yes, you can do. In 22 years of active telemedicine and having overseen with my staff and all that we have actually done 10 million teleconsultations altogether in the last 20 years. We do not take audio recordings. I write there consent obtained from so and so at such and such a time. The court takes my word for it. I am not a criminal. I am not primarily there to protect myself. I don't know why we are all getting so worked up about this.
There are lots of questions on the medico-legal implications. As you said, we should not be paranoid for it. I think that answers the question. Now, coming to the surgical practice, we have some surgeon doctors too who are attending this webinar. How can telemedicine come to the aid of surgeons? Because surgical skills form such an important part of an OPD practice during, for the surgeons.
Sir, I am a neurosurgeon. Neurosurgery may be different from general surgery. I'm not in active neurosurgical practice, but from 1975 to 2015. So I think I have enough experience. And 90% of the post-operative cases, I'm talking of neurosurgery, I have personally, I try my best to discourage them from coming hundreds and hundreds of miles away. And our general surgeons also use telemedicine to a large extent. So for review cases, I totally agree with you. As things stand today, you can all see a lot of things you can do. A multinodular goiter. Let's take a person with a multinodular goiter. With a good remote clinical examination, I can make out whether he's got a recurrent laryngeal nerve palsy or not, whether it's infiltrated or not. I can make him swallow. Whatever you do, I can ask somebody to put a stethoscope over that multinodular goiter, find out whether there's a bruit. That bruit can be, whether there is a sound, it can be transferred. I cannot look at a thrill, but those days are slowly going. I'm sure your surgical decision, whether to operate, what to an extent, what type of surgery you will do, etc., is more governed by the ultrasound findings, MRI findings, and so on and so forth. Now, please remember that this is what I have done in hundreds of neurological cases. I discuss with the patient, I look at the MRI, I say, you have a posterior third ventricular tumor, this is what you need. You have a brainstem glioma, we need a CT guided stereotactic biopsy. I explain everything to him. I fixed up surgical procedures so many times with patients from all over India and outside India, and surgery is fixed. I say, we'll get an anesthetic opinion. You must come on an empty stomach. An anesthetist evaluates all the laboratory reports, everything remotely, and then the patient comes on an empty stomach the previous evening. So we admit him the day before surgery. All these things can be done to a large extent. I'm not for a moment saying a surgeon should dispense with clinical medicine. I mentioned again and again, if you are comfortable with a rectal examination, no telemedicine, as simple as that.
Sir, you have already deliberated upon this point in your talk, but if you could elaborate once again on the training module which the TSI is planning to come up with for the physicians and other doctors.
Okay, there are two things. Training module is different from orientation sensitization. Orientation sensitization, we have already come through. We have already done this on about 1,700, 1,800 doctors so far. And up until May 2nd, it will be free. After that, there'll be some nominal amount. That is a 2.5 to 3 hours. There are 3 modules of 20 minutes each. It can be self-learning also. Anybody who registers, you will have access to the 3 modules, and you go through the 3 modules, and then you come online, and just like you're doing now, and we'll have 3 or 4 very experienced, highly articulate, competent, qualified people who will act as moderators, just like what we are doing now. Whatever question you want to ask, you ask, and they will answer. That will take about 1.5 hours. So 1 hour of seeing modules, 3 modules, and 1.5 hours of FAQ, so 2.5 hours. You will get a certificate of participation issued by TSI and possibly countersigned by MCI. We're still not sure of that. That is a sensitization program. What the MCI has made compulsory in the practice guidelines is they have given a long time. They've given 3 years time. Within 3 years, every doctor in the country who wants to practice telemedicine must produce evidence that he has satisfactorily undergone a formal course in telemedicine. We are still working out the details. It could be 40 hours, it could be 50 hours. Most of the course will be online. We are still not sure whether there's going to be a practical element in it or not, or even that will be virtual, etc., etc. There'll be an examination, self-assessment. This will take at least 7-8 months before we are ready with the course. But the government has given you 3 years time to do this. After 3 years, the exit exam, the final MBBS exit exam, we are assuming will contain a subject or something like that on telemedicine. So it will be part of your registration process.
Thank you, sir. I think we do not have any more questions. And with this, we would like to come to the end of this session. But before we close, my sincere thanks to you, Professor Ganapathy, for sharing your rich and extensive experience. And I would also like to thank all the participating doctors who have spared their valuable time and who have logged in for this session. I think we are definitely benefited with this very elaborative and informative talk. And there are certain take-homes for all of us, for the clinicians, which would definitely help them in their practice. With this, we end this session here. Thank you, one and all.